Dr. Manoj, Dr. Purvi, and the team, scientific team of DRS for inviting me. Dear friends, we are hearing since morning regarding the hypertension by Dr. Anuj and then few controversies regarding the air pollution and the other low blood pressure, etc. But this controversy, sort of controversy, is not there. But let me clarify the beta blockers used in diabetes. Beta blockers are very, very important molecules to be there in the armamentarium of the management of hypertension. These are my disclosures. Dear friends, what I'll be speaking is the clinical context of beta blockers. The important aspect is that we have already heard that 70 to 80% of type 2 diabetes patients have hypertension, which we have already seen since morning. Once the patient is having hypertension and diabetes, there is a 3 to 4 fold increase in the incidence or prevalence of coronary artery disease. Beta blockers are very, very important molecules which improves the outcome of, especially in the post myocardial infarction and also in the heart failure patients. So beta blockers are important molecules, and how to use judiciously, let us see. And what we are concerned about the use of beta blockers is the worsening of glycemic control, one thing, hypoglycemia unawareness, second thing. So these are the two major concerns while we are using the beta blockers in diabetes. And of course, there is a clinical challenge in balancing the cardiovascular protection. So what is our aim of managing hypertension in diabetes is this, the cardiovascular protection and the metabolic derangement. So let us see some of the aspects, the intricacies of beta blockers. We all know about the pathophysiological mechanism, and of course, there are certain genetic factors, polygenic diseases there. We have the acquired factors, environmental factors. Dr. Vitul have just mentioned about the air pollution and several other factors. But what it ultimately does, either there is inflammation or the oxidative stress, and on the other side it is the insulin resistance, which leads to hyperglycemia, dyslipidemia, hyperinsulinemia. So the most important factor is, after that, either there is an activation of RAS, and another side there is the activation of sympathetic nervous system. So these are the two major factors which are there in the hypertension in diabetes. So we have a very special situations with the diabetic hypertensives, that most of the diabetic hypertensives have systolic blood pressure high, autonomic neuropathy is there. That's why there is a fluctuations or especially less reduction of nocturnal blood pressure. There is an enhanced blood pressure variability, high baseline heart rate, and there are several other important features. I'll go into the details little later. So what are the concerns? First concern is masking of hyperglycemia. This is major concern while we are using the beta blockers. Peripheral vasoconstriction, and of course the insulin resistance. So what is the therapy of diabetes in cardiovascular disease? In 2023 systemic review and meta-analysis, beta blockers application may improve all cause mortality and cardiovascular death in coronary artery disease, especially the myocardial infarction in the diabetes patients. So this is the systematic meta-analysis showed. So what is the pharmacotherapy of hypertension and diabetes? There are four major molecules. One is the important molecules we have seen, the ACE inhibitors and ARBs, alpha blockers and beta blockers, calcium blockers, and the diuretics. And if you see here, the very important aspect that these molecules, they ACE inhibitors and ARBs, they actually increases the RAS activity, and that's why they block the vascular tension and ultimately manages the hypertension. The alpha blockers and beta blockers, especially the sympathetic nervous system, which is heightened in the diabetes patients, and they control that. Diuretics increases the amount of sodium is controlled by the diuretics, hence the circulatory volume is reduced and the hypertension is managed. And of course, we know that calcium blockers, they reduces the vascular tension, reduces the peripheral vascular resistance, and improves the hypertension. So what are the basics of beta blockers? The basics of beta blockers are, the important thing is that you have to remember the cardioselectivity. It is the beta 1 blockers which are very, very highly cardioselective beta blockers like metoprolol, bisoprolol. So they cause less bronchospasm, and of course little metabolic concern is there. There are certain non-selective beta blockers which block both beta 1 and beta 2, like propranolol, which increases the insulin resistance, and of course they mask the hypoglycemia. There are vasodilatory beta blockers like carvedilol, nebivolol, and they have the very better metabolic profiles. So still, what is the mechanism of concern? That there is a decreased insulin sensitivity via beta 2 blockade. That is important thing you have to remember. And reduced muscle perfusion, which increases the impaired glucose uptake. So there is a hepatic glucogenolysis suppression, and that's why there is a masking of hypoglycemia. And of course, cardioselectivity matters a lot when you are choosing any beta blockers. So there are several features by which beta blockers should be used. I will not go to details, but beta blockers actually are very good molecules which actually are useful in the cardiovascular continuum. If you see here, whether the patient has hyperlipidemia, hypertension, diabetes, or smokers, LVH, atherosclerosis, coronary artery disease, myocardial ischemia, coronary thrombosis, infarction especially, and post-myocardial infarction, beta blockers are very, very good molecules. And through the whole cardiovascular continuum, the beta blockers are being used. So in hypertension, the beta blocker can be used as a monotherapy as well as a combination therapy with AR base. In heart failure, beta blockers are still a cornerstone management, and especially in the reduced ejection fraction heart failure, and of course in coronary artery disease. So there are different classes of beta blockers. There are relative beta 1 selectivity, non-selective beta blockers, and beta 1 selective beta blockers are there. And especially if you see here, the beta blocker selectivity is very, very important. Bisoprolol has very good, highly selective. Of course, other beta blockers are also selective, except the propranolol, which is non-selective beta blockers. And of course, the pharmacokinetic variability is again very important for beta blockers. And if you see here the pharmacokinetics of different beta blockers, bisoprolol fares little better than atenolol, metoprolol, carvedilol, and nebivolol. So the main important concern here is the risk of new onset of diabetes. And the Mayo Clinic has cleared that meta-analysis of beta blockers in the new onset of diabetes risk by 22%. That was the first publication. And the risk was highest with the non-selective beta blocker. That is the important thing. And the mechanism of diabetogenesis is that we have already seen. It is the beta 2 inhibition in the pancreas which reduces the insulin resistance, increases the hepatic gluconeogenesis, increases the visceral fat accumulation, and that's why ACE inhibitors and ARBs fares always better. ADA 2025, very recent recommendations, they say that beta blockers are not the first line, but they are recommended in the heart failure, post-myocardial infarction, and certain arrhythmias. Especially in the hypertension, why beta blockers are very, very useful. And this is the reason that central obesity is one of the important aspects, and through the insulin resistance insulin norepinephrine release, there is increased risk of ventricular arrhythmias, plasma renin activities, angiotensin 2, and through these mechanisms, it is the beta 1 adrenergic stimulation which is very, very important. And hence, when the sympathetic system is heightened in the elevated hypertension and diabetes, as you see here, that is the important aspect, and that's why the beta blockers are very, very useful, especially the highly selective beta blockers. And this is very important slide, that it is the combination of beta blocker and AR base. This is very, very important, which is published very recently, that the combination is very good. Beta blockers reduces the norepinephrine release, and AR base reduces the angiotensin 2, which is a murder molecule sort of thing in hypertension. So if you combine beta blockers and AR base, that is the best management in the hypertension and diabetes, especially in the cardiovascular, this coronary artery disease. And the important thing, this is again a forest plot, and if you see here, it is shift to left in most of the aspects. The beta blockers can be used to reduce all-cause mortality in patients with coronary artery disease and hypertension and the diabetes. So that is very, very important. Again, the newer AHA, ACC guidelines, they clearly suggest that beta blockers are essential for reduced ejection fraction heart failure, post-myocardic infarction, and the stable angina. But you have to avoid the beta blockers as monotherapy in uncomplicated hypertension. And the important aspect is that even NICE guidelines in the hypertension recently, they also suggest the similar thing, that the third generation beta blockers are favored in the diabetes. If you see here the heart failure, I'll not go into the details. This is the one thing I want to tell, that increased doses of the beta blockers are very, very useful once you have a reduced ejection fraction heart failure. So clinical decision can be taken. You have to assess the primary hypertension or post myocardial infarction or reduced ejection fraction heart failure. Always think of using the beta blockers. So these are the practical tips. Last slide of mine. Counseling of patients when you are using the beta blockers in diabetes. First thing, encourage regular self-management of blood glucose. Again, very important. Once the patient is on beta blockers, regular monitoring of blood glucose is needed. You have to monitor lipids, glucose, and HbA1c very periodically. And of course, avoid abrupt withdrawal and taper the dose very gradually if you want to avoid or you want to stop the beta blockers in the management of diabetes hypertensive patients. So final takeaway, this is not the first line, of course. It is indicated in reduced ejection fraction heart failure, post-MI and arrhythmias, and choose the agent thoughtfully, judiciously, and prefer the most selective beta 1 blockers like carvedilol, nebivolol, or bisoprolol. They are very good beta blockers, can be used in certain conditions. So thank you very much for the patience listening.